Hi everyone, and welcome to the Emergency Medicine Clinics podcast. I'm Jo Gascoigne, the managing editor for the series here at Elsevier. Emergency Medicine Clinics is a quarterly publication consisting of review articles focused on a central topic. Today, we'll be discussing the August 2024 issue on environmental and wilderness medicine. Joining me today are Dr. Cheyenne Fallett and Stephanie Leroux. Let's dive in and explore the first featured article from your edition, Heart-Related Illnesses, by Jonathan Bowman, Suzanne Spano, and Michelle Storken. Could you provide us with some key points or highlights from this article?
Yeah, so heat-related illness is very important because even as we move into the fall, heat-related illness can definitely happen. The most serious heat-related illness that we worry about is heat stroke. And that's when somebody's body temperature usually is above 103 or 104 degrees Fahrenheit, and they start exhibiting signs of altered mental status, an altered level of consciousness, or abnormal neurologic exam. One of the most important things for heat illness is trying to prevent and be prepared to deal with it, as this happens a lot in athletic events. Cheyenne, you said that you'd had some recent experiences with some heat illness in a marathon?
Yeah, absolutely. So the Baltimore Running Festival in Maryland, where I live and where I practice, occurred this past weekend. And it was rather warm here in Baltimore, reaching about 80 degrees Fahrenheit. And we actually saw across a few of our hospitals in the city quite a few cases of not only heat exhaustion, but heat stroke. Thankfully, they were treated appropriately in the pre-hospital setting. And although they still had some complications upon arrival to the emergency department, the care that they received pre-hospital was life-saving.
And that's a really important point with heat illnesses is typically what happens in the field really sets the clinical course. So many events will actually have immersion baths with cold ice water that they can put athletes in if they're showing signs of heat illness to rapidly cool them. And cold water immersion is the best way to cool people rapidly. I know out in Phoenix, the emergency departments have seen a lot of increased incidents of heat stroke and heat-related illness this year with some of the heat waves that have gone through, and have actually started using body bags packed with ice and water to cool patients. Cheyenne, is that something you guys are doing in Baltimore too?
Absolutely. What I tell my residents actually is either you place the patient in a body bag right up front, or they'll be placed in a body bag later on in their care, which is a little bit morbid, but it really hammers the point home that that's truly the best, and I think in the emergency department, the most feasible way to rapidly cool someone and give them a shot at life-saving care.
Definitely. And I joke with our residents as well that you have to use good clinical education to the staff and to the patients and their families when you're putting people in body bags, because that's not something we typically do with alive patients, but a very cool, innovative way to cool people down rapidly.
And make sure when you put the body bag on the bed that you leave the opening for the zipper up by the head, because a few times we've gotten into the situation where it was placed the wrong way on the bed, and then we kind of had to jerry-rig closure of the bag at the feet. Yes. And at the abdomen.
In the field, they use a method called the taco method, in which you can take a tarp and put ice and water on the tarp, and people standing at all four corners and edges and kind of oscillate the water over the patient. So then you get not only the contact with the cold water with the patient, but you also get a little bit of convection of the fluid over the body to help cool them down rapidly. So if you're in an athletic event or out enjoying nature, that's another option to cool people down.
Now, Steph, a lot of residents ask me, exertional versus classic heat stroke, is there really a difference in how we approach it?
From an emergency department standpoint, there really isn't. The goal is still just to cool people down rapidly, regardless of what is causing the heat stroke. I think during the summer it becomes a little bit complicated because sometimes we'll see sepsis patients that also have really high temperatures up in the 103 and 104 ranges. So really getting that history is important, and kind of keeping a wide differential when you're taking care of patients and not forgetting sepsis and infection, neuroleptic malignant syndrome, and other etiologies of elevated body temperature when you approach the patients. Important to always remember that using Tylenol or acetaminophen or ibuprofen is not effective and actually can do more harm in heat-related illness. So really trying to differentiate those patients is important when you start thinking about treatment.
Because it's not truly a fever, right? It's an elevated temperature.
Exactly.
So those are the antipyretics really don't do much. And dantrolene is kind of in that same category, right? Where there really isn't any evidence to support its use.
Exactly. That's completely correct. And heat stroke. And you think patients with heat stroke a lot of times are having, liver and kidney issues due to the elevated body temperatures. So those medications that are metabolized in the liver and kidneys can actually cause additional harm.
Yeah, great information in this article, truly, for how to take care of patients. One more thing, disposition-wise, like for the patients who came in from the marathon, I believe one that I'm aware of in particular reached a core temperature of 108 in the field and was cooled, but already started to show a little bit of a bump in their liver enzymes when they were brought to the emergency department. Is that someone who we can discharge home for outpatient labs, in 1 or 2 days, or is this really someone who we need to keep a close eye on and admit to the ICU?
I feel that typically a lot of these patients do end up getting admitted, especially the ones coming in with heat stroke, kind of for trending of laboratories values and more supportive care measures that can happen in the hospital. So I think once you're checking labs and, a lot of times we also see elevated troponins, these patients will need to be admitted for observation for, a period of time afterwards and usually aren't getting right back to their athletic endeavors.
Excellent points.
Biggest take-home message is being prepared to treat heat-related illness, have those things together to cool patients down and really have a plan in place before you have to take care of heat stroke patients. One of the big things I feel like most of us see in our emergency departments is we don't see these environmental emergencies with the same frequency. We see, abdominal pain and chest pains and things like that. So having a high index of suspicion and then having a pathway to follow can be really helpful.
And then for our patients, prevention and education really are key. So adequate hydration, avoiding the highest temperatures during kind of the peak heat hours and really being able to recognize when you start to overheat and remove yourself from that heat.
Definitely a huge role for patient and public education.
Thank you. Let's now turn our attention to another noteworthy article that you wrote yourself, Cheyenne, Environmental Hypothermia. Could you please share with us your insights from this article?
Yeah, so covering everything from hot to cold, right? So hypothermia is actually what interested me in the first place in environmental and wilderness medicine. So it really holds a special place in my heart. The mortality for severe hypothermia can range upwards of 50% up to almost 80%. If not recognized and treated. And the statistics just always astonish me. So the lowest temperature that a hypothermic cardiac arrest was successfully resuscitated from was down to 13.7 degrees Celsius. The longest avalanche burial time leading to a hypothermic cardiac arrest from which a patient survived was 7 hours. And the longest period of submersion in icy water of which a hypothermic drowned cardiac arrest patient was successfully resuscitated from was 83 minutes. That's wild.
That's wild. That definitely makes you remember that caveat. You're not dead until you're warm and dead is really important to remember.
Yeah, my patient that kind of spurred my interest was one February. He was kind of stumbling along, intoxicated along the edge of the harbor and fell in and became submerged. And he was underwater for about 25 minutes and eloped from the hospital neurologically intact 3 weeks after he was brought in and without a pulse for almost 4 hours. So really just like in those heat strokes, keeping a high level of suspicion for heat-related illnesses in the wintertime, and not just places that are historically cold, but mostly even the temperate climates and those that experience kind of considerable changes in temperature between day and night. Those kind of areas are at particularly high risk of their inhabitants experiencing hypothermia and hypothermic arrests. So really keeping a high level of suspicion for their care. There are certain people at risk for hypothermia more so than the general population, and those include infants and elderly patients, those who live in urban populations, and patients with concurrent alcohol or substance use and psychiatric or socioeconomic barriers that prevent sheltering from cold, patients with very low body mass index who don't have the caloric stores or the caloric intake to support shivering and other intrinsic abilities to generate heat. And then those with certain comorbidities that either impair thermoregulation or decrease heat production or increase heat loss or necessitate medication use with, for instance, alpha blockade or kind of opioids or benzos. Those can all be patients who are at increased risk of suffering from hypothermia. This article does review a lot of the pathophysiologic changes that occur in patients with hypothermia as you kind of ramp up. Kind of everything ramps up in mild hypothermia. So you get tachycardic, you get tachypnic, you can be fidgety and have kind of shivering and impairment with fine motor skills. As you fall into moderate hypothermia, kind of everything slows down. So you can have various dysrhythmias, including atrial fibrillation with slow ventricular response. You have neurologic slowing. You have kind of bradypnea, and then all of that continues to degenerate as you fall into severe hypothermia until everything kind of stops. You experience apnea, you experience ventricular fibrillation and asystole, and patients can appear dead. But as you alluded to, you're not dead until you're warm and dead in hypothermia. So classic signs of death, including fixed and dilated pupils, apparent rigor mortis, or even dependent lividity, cannot really be interpreted in severe hypothermia. So you still need to continue resuscitative efforts for those patients. As far as
what are some things that you would that you guys do to try to start making people warm?
Definitely. So it kind of depends on the stage of hypothermia. So if patients are maybe just a little mildly hypothermic, you can use something like passive rewarming. So preventing further heat loss, allowing patients to shiver, giving them warm, generally caloric fluids like broth, or even hot chocolate, something like that, and then providing them with warm blankets. As you kind of tip into moderate hypothermia, they may require active external methods of heat rewarming, so using a forced air device, such as one that is frequently available in postoperative care units and stuff like that. But then as you tip into severe hypothermia and you are at high risk of experiencing a hypothermic arrest, that's when our various active internal rewarming techniques are really going to be key. So you can do various lavages from thoracic to bladder to even gastric lavage has been reported in the literature. You can use various intravascular rewarming catheters, continuous renal replacement therapy, and then escalating up to what has kind of become the gold standard in hypothermic arrest rewarming, which is extracorporeal membrane oxygenation, or ECMO, another term for that when it's used to rewarm patients who are pulseless is ECLS, extracorporeal life support. And patients should really be considered for that, but not everyone who is in arrest will benefit from it, and there are various scores that we can use, the gold standard of which has really become the HOPE score. So you can calculate a person's chance of survival following ECLS using the HOPE score, and then that score is used by our cardiac surgeons to really determine who gets ECMO and who should be rewarmed with kind of the less invasive modalities.
Yeah, definitely. I think the HOPE score is something that we've put into place here in our protocol with our cardiothoracic surgeons to kind of decide who would be a good candidate for ECMO. And it's interesting, potassium goes into that, and a lot of times we think about patients not being, viable anymore when the potassium gets to a certain level, but there have been some pretty high potassium levels that we would not consider compatible with life that people have been resuscitated. So typically people use a potassium cutoff of 10 to 12 when they're deciding which patients to potentially continue resuscitating.
Yeah, but even that potassium cutoff, so when people use the HOPE score in contrast to the potassium level, they found that an additional 27% of ECLS attempts could be avoided without any additional loss of life, which is important when considering a procedure like ECMO that's very resource intensive. You want to use it for the right people because these patients can survive with profoundly good neurologic outcomes, but at the same time, it's a very it's a very kind of resource intensive procedure, and you don't just want to use it for people who won't benefit from it. So the HOPE score has actually largely replaced just the potassium alone in determining who gets kind of continuation of resuscitative efforts. But you mentioned the potassium, so you have to know when to terminate these resuscitations too, and definitely a potassium level, if the patient has greater than 12, you can actually terminate resuscitative efforts even prior to full rewarming if they demonstrate that high of a level.
Yeah. What about other medications, Cheyenne? I think that's something I always kind of talk to my residents about is, it's really hard as an emergency physician to see somebody who's bradycardic and hypotensive and not reach for those pressors. What do you kind of tell your residents?
So these patients are interesting in that there are some deviations from kind of routine care that we provide for these patients and routine ACLS. So even though some of these patients can be profoundly bradycardic and profoundly hypotensive, their rate of oxygen consumption, their metabolic needs are so drastically diminished when they're severely hypothermic that they don't actually need that blood pressure or heart rate support oftentimes to support what their oxygenation needs are. So the various societies, including the European Resuscitation Council and the Wilderness Medicine Society in their latest practice guidelines, actually recommend withholding vasoactive ACLS medications until patients have been rewarmed to 30 degrees Celsius if they're in arrest, and then doubling the standard dosing intervals when the core temperature is between 30 and 35 degrees Celsius. If they've been rewarmed over 35 degrees, then we recommend kind of continuation with routine ACLS medications and potentially pressors if needed as well. But really below that 30 degrees, I would avoid epi, I would avoid any of those other pressors. And defibrillation attempts as well. Like if someone is severely hypothermic, it has been shown really not to be as effective. So the latest guidelines come from the European Resuscitation Council, and they recommend only up to 3 defibrillation attempts for hypothermic patients with core temperatures less than 30 degrees. And if unsuccessful, really withholding further attempts until that patient is rewarmed to 30 degrees Celsius.
That's super important to remember, because I think it's easy when you have a patient in arrest to kind of fall back on your normal ACLS, and that's kind of what everyone in the room wants to do. So really educating the providers that you work with and yourself on these guidelines, I think is beneficial for the patient, because we all know, you've got to fix the underlying problem, which is the hypothermia, in order for these medications and defibrillation attempts to stand a chance of working.
Absolutely. And how do you even know when someone is hypothermic? Like how do you measure that temperature? Because a lot of thermometers are not actually accurate below about 34 degrees Celsius, our typical like infrared and mercury and alcohol thermometer. Yeah. So really the recommendation is for an esophageal temperature probe for intubated patients, but also with the caveat that you need to know how to place it, and it needs to be placed really in the distal third of the esophagus to provide the most accurate measure of core temperature. But for a non-intubated patient, so you know how we can measure these temperatures.
Yeah, so there's, some thought of doing rectal thermometers for a core temperature, and that's probably your next best option. A lot of times a Foley catheter, if you're doing bladder lavage, that's not going to be a good option for temperature. But as far as what we have in our emergency department, we usually kind of go to the rectal temperature next. But definitely that core esophageal temperature is really what you want to do. And most of these really sick patients are going to be intubated, so that's something to keep in mind.
Yeah, that's what we do as well. If they're non-intubated for whatever reason, like they're right on that cusp of moderate and severe hypothermia, and they're still maintaining some respiratory drive, then the rectal temperature probe is the next best step. But again, with the caveat, you need to know how deep to insert it if you want it to be most accurate. So it really has to be inserted to a depth of about 15 centimeters in order to use it as a surrogate for core temperature. But a lot of, if I may say so myself, a lot of great information on logistics of how to recognize, how to care, and how to disposition these hypothermic patients in here.
Yeah, definitely. I think it's a really good thing to brush up on as we enter the winter season, because we're seeing more and more patients that are presenting like this. And I think as the awareness grows, we continue to also provide better care for these patients.
Let's now focus on another significant article in your publication, Cold Injury by Jennifer Dow. From your perspective, what were the standout points of this particular article?
Yeah, so it's a nice kind of corollary to the hypothermia article, considering that cold injury encompasses hypothermia, but also freezing and non-freezing cold injuries. So it's really important when caring for frostbite that you recognize it early and you remember that time is tissue. So you want to provide rapid rewarming for frostbite. You want to recognize it early, but you don't want to warm too early. If there is a risk of refreezing injury for these patients, it can actually worsen the extent of the frostbite. So you really want to make sure that you start your rewarming as soon as possible, but only once you can guarantee that you do not have any further freezing risk to that limb. Frostbite is can result in a lot of downstream effects, especially if you will eventually require amputation, and it can prevent people from executing their jobs appropriately, or from being able to participate in what they feel is a meaningful way in society or personal activities. And frostbite is actually the most common cold injury reported by the U.S. Armed Forces. I was surprised to find that in this article. But it's also important to remember when you care for these patients that you want to do early imaging. So as soon as you have a chance, you do want to be able to obtain angiography for these patients once they reach your emergency department, because that will really guide any further thrombolytic or even iloprost therapy. And that's really the big ticket item here in the United States this year, is that iloprost was approved by the FDA for the treatment of frostbite injuries. So we're finally joining the ranks of countries, for instance, all across Europe, in that it is now approved for the treatment of frostbite. Isn't that exciting stuff?
That is really exciting. I think the challenge is, in talking with our hospital pharmacists, we don't stock iloprost still. So that is definitely an added challenge. Do you know if you guys are stocking it?
I was told earlier that we will hopefully be ramped up for it by the winter time. So I will have to check with our pharmacists again, but similar issues with availability for sure.
Yes, but really exciting, because that kind of puts us forward, with our colleagues in Europe and Canada that are using this medication that has some really good evidence of helping preserve function and save tissue. And
it's been in use for a while. The first use in frostbite treatment was reported in 1984 back in Austria. And the studies do show that it demonstrates a reduction in amputation need compared to controls when used. And it can be administered up to 72 hours out from tissue thaw. So it doesn't really have to be administered right away in the emergency department. But it can, even if there's some delay in thawing of these injuries, it can be administered up to 72 hours out, but the earlier the better. You should be, yeah.
Really important, I think, if you're working in a smaller critical access hospital or somewhere that's more remote, or even in a field hospital, that there is still great benefit in getting people to definitive care or somewhere that has this available.
Absolutely. And its use should really be considered in patients with grade 2 to 4 injuries. So any time that the patients start to demonstrate some cyanosis after thawing, those really are the patients to consider its use. Now, what's notable is that it is a continuous infusion over about 6 hours, and it is administered for about 5 to 6 consecutive days. So that is your disposition with these patients, if you choose to go the iloprost route, is that these patients do require admission and repeated dosing of this medication.
That's something interesting to think about. A lot of the patients that we see here in the Roanoke area with cold injury have housing insecurity and are often, out in the cold weather and maybe not by their own choice. So what kind of resources do you think patients need to kind of prevent this?
Yeah, so it's really avoiding cold exposure is prevention of frostbite, but that can be impractical, like you mentioned, especially for those facing housing insecurity. So it really is important to increase your education of your patient population. A lot of those with housing insecurities are those patients who I probably know their name, birth date, and where to find them in my city on any given day. Yes. So they're patients with whom I become familiar, but really, really educating them on if it's anticipated to be cold or if that cold blue alert goes out, really try to go to that shelter. Those are not the days or the nights to try and just be out on the street on your own. Cities around the Northeast, and I'm sure elsewhere in the countries, really ramp up their shelter and other resources during those extreme cold weather events. And patients should really be encouraged to take advantage of them. The recognition of these injuries may also be impaired, like if the patients are intoxicated or if they have substance abuse issues, which many of them do concurrently. So it's a real struggle, Steph, especially for those inner city populations.
We see a lot of people that, they come in later after the presentation because they didn't really know what to do, or sometimes people make mistakes when trying to rewarm the tissue too, especially people that are, have a campfire or something like that. They'll actually try to warm the cold tissue over fire. And because the sensation is so poor, then they have a risk of having burns on top of their frostbite. So that's something always really important when you warm. I think immersion and kind of a circulating hot water bath is one of the best ways to warm, but making sure that temperature is not too hot, because when the patient puts their hand in there, they're not going to have the sensation to know that.
Yeah, so this article really does a nice job of describing exactly what you're talking about. So the do's and don'ts of rewarming. So it reminds us not to rub or massage the skin, as that can cause additional injury, not to apply dry heat to the injury. So again, holding it above a campfire, not the way to go. What you want to do is to wrap the area with a dry protective dressing, such as a bulky gauze, and protect against mechanical damage. Like you said, a lot of it is insensate or they experience loss of sensation. So splinting it, if necessary, to provide additional mechanical damage. And then using kind of whirlpool immersion or a modified version of that if you don't have a whirlpool at your hospital, which we certainly don't. But you want to warm the water to about 38 to 39 degrees Celsius, but definitely try to keep it circulating to maintain a more consistent temperature. So the way that I do that functionally in our emergency department is getting just a basin, putting the basin in the sink, letting the sink run with continuous water, and then sticking a thermometer in the water and making sure that we kind of fine tune the hot and cold ratio of water to about that 38, 39 degrees.
Yeah, I've definitely seen some case reports with people actually using the food grade sous vide to heat water for frostbite care, which is a novel way to use a device that we usually use for other things.
Right. Just explain to your patients, that you're not actually preparing their limbs for freezing. Now, I always get questions from my residents and others about what to do with blisters, like in general, what to do with blisters, but specifically for frostbite. So this article does also nicely remind us that clear blisters, if they're too large or they interfere with movement, they may be aspirated, especially or even in the field, but leave those hemorrhagic blisters alone in the field. So kind of let the limbs declare themselves. And if you don't need to, try not to interfere with the blisters for frostbite patients.
Yeah, I think it's always really interesting when you see some of the case reports and things in the literature where, these have some really horrific appearances of toes and fingers. And then when you look at the clinical course, a lot of times more tissue can be saved than what you would initially think looking at someone. So I think it's important if you're in an area that you don't see a lot of frostbite, making sure that your surgeons don't do too much debridement too early and kind of see what tissue is actually going to remain viable.
Yeah, this article reminds us of the common saying, freeze in January, amputate in July. So definitely waiting conservatively with any kind of operative intervention until the injuries fully declare themselves. Absolutely. So nice timely reminders kind of as we move into the winter. And then the other thing is kind of what other medications can we use? So NSAIDs, Steph, yay or nay?
Yay.
Yay. I love it too. And NSAIDs, it's not only providing analgesia, but they can actually decrease the production of prostaglandins and thromboxanes, mediate some of the vasoconstriction and progressive ischemia that we see in these injuries. So it's not only for pain relief, but for progression of their symptoms as well. And then what about thrombolytics?
Another yay.
Another yay, absolutely. So now with iloprost hopefully becoming more widespread across the country, those kind of moderate cases of frostbite, we may or may not be doing thrombolytics anymore if we prefer to go with iloprost. But absolutely for those more severe frostbite grades and those where iloprost is not available, thrombolytics are important. Frostbite is an ischemic injury. And just like with, strokes or MIs, restoring circulation does limit the tissue damage, as reminded to us by these articles. So really you want to get these thrombolytics within the first kind of 24 hours and potentially reverse some of their ischemic injury.
Yeah, and interesting also, hyperbaric oxygen therapy is another thing to consider, especially long-term, trying to help salvage tissue that's been damaged by frostbite. We don't have that as an option here within our hospital, I guess, as outpatients for wound therapy, but that's something else to think about in the long term.
Which brings up a good point, is that regardless of where you are, I think knowing where to call for resources is important. So even if you don't have hyperbarics at your own institution, maybe these are patients worth considering transferring out for hyperbaric care. But these are decisions that can definitely be made in consultation with vascular surgeons, even if you're not operating right away or even in the first few weeks. They can definitely help you make some of these decisions together. So know who to consult, know what resources are available to you locally and available for transfer, and know not just what your pharmacologic options are, but like Steph and I mentioned, the availability of them. And hopefully iloprost will become more available at more institutions as we move further out from the FDA approval.
Yeah, and I believe University of Utah actually has a frostbite hotline phone number that you can call and get in touch with frostbite experts that can help guide your consultants in your care for significantly frostbitten patients. So something else, another good resource to know about.
Awesome. Well, it was an excellent read, especially as we move into the winter months, and I'm sure that I will be using a lot of pearls from this article in the care of my own patients.
Most definitely, especially as we work on trying to get iloprost more readily available in our emergency departments.
Definitely.
Closing out our discussion, let's discuss an article on drowning, co-authored by Christopher A. Davis and yourself, Stephanie. Could you share your insights on the notable features or key points of this article?
Definitely. Drowning is something, unfortunately, as more people enter aquatic areas that we're seeing more and more in the emergency departments, and important to be comfortable with it and comfortable managing that airway. Cheyenne, I don't know, have you had a chance to manage any drowning airways in your practice?
I have, unfortunately, quite a few, kind of living on the water here in the city, we do see quite a bit of drownings. And even in the news recently, I don't know if you saw, Stephanie, but there is a famous surfer, Bethany Hamilton, whose nephew just drowned, very unfortunately. And this just goes to say that even in the most cared for, families, the most cared for situations, drowning events can happen accidentally and precipitously, and kind of safety around aquatic environments is extremely important. But yeah, these airways can be quite difficult to establish. Yes. A lot of frothy secretions in there.
It's very challenging, not an airway that you really want to face, but an airway that you need to face rapidly, because kind of the common pathophysiology for drowning is it is a hypoxic arrest, meaning the patient's not getting the oxygen that they need. So getting them oxygen as fast as possible and as effectively as possible is really key to survival. When you see that frothy sputum, a lot of times you want to reach for the suction and try to suction out that airway to kind of get a better view and try to get some of that out of the airway, or maybe even after you've placed an ET tube, you still feel like you need to suction. But in fact, that froth is coming from surfactant and coming from damage to the lungs. So unlike vomitus, it's actually better to go ahead and just bag through that, go ahead and ventilate through that to try to get oxygen into the lungs. So a little bit counterintuitive. But some of the worst airways I've seen have been drowning airways. And, sometimes you end up having to move toward the surgical airway if you're unable to get a view to get that ET tube in place.
And these drowning airways that I've experienced have also been quite edematous. Too, and you add the edema and the froth, and like you said, trying to maybe avoid suction, and you can't get any view. Those really are. I have to agree with you. You have to be ready to move on to plan B, C, and D for these airways, and not linger on trying to get a good view.
Because oxygen is key, and it's interesting in literature looking at care in the field. Early rescue breaths are predictors of improved survival. So when rescuers go into the water to actually get a drowning patient, giving early rescue breaths, sometimes even before getting them out of the water, if they have that skill set, can improve survival. One of the challenges that we have with the new CAB concept, or a lot of the new hands-only CPR, is that people that are enjoying water sports and recreationally don't know that if a patient is drowned, that those rescue breaths are really key, and the hands-only compression is probably not going to be quite as effective in resuscitating the person. So definitely something to make sure if you're educating lifeguards, if you're educating people that are partaking in water sports, to make sure they do those rescue breaths early and really prioritize the breathing part.
Absolutely. Now, what if stuff like the patient doesn't require intubation, and I can get away with doing something like BiPAP or non-invasive positive pressure ventilation? Let's say I get them stabilized on the non-invasive, and they're doing a little better even while they're in my own emergency department. I can't get an ICU bed because they're boarding in my ED. Can I start to wean them after a few hours like I would someone coming in with flash pulmonary edema if they're looking better?
Yeah, usually their course is going to be a little bit longer just because the pathophysiology is different. So a lot of these people are going to require a little bit more support longer. Definitely always good to wean and think about lung protective strategies. But a lot of times it'll be a good 24 to 48 hours. It's tough, as emergency physicians also, we see these, horrible whited out chest x-rays from a drowning patient, and we want to hop to the antibiotics and to the steroids. But there is not much efficacy for steroids or antibiotics, with the caveat of someone, drowning in like a septic tank or something. You need a lot of bacteria in the water. Our general recreational waterways don't have enough bacteria to really cause a true pneumonia. So it's more of a pneumonitis that occurs. So kind of ARDS-NET and lung protective ventilation strategies are key. And then really just supportive care and that positive pressure.
Yeah, absolutely. It's funny you mentioned that, because here in our Baltimore Harbor, we just reached minimum legal limits of fecal contamination a few years ago. But before we reached that, our water was quite gross. But the patients that I've had who have truly drowned in our harbor, like you said, we didn't start empiric antibiotics, and I was surprised how few of them went on to develop a pneumonia, even despite how contaminated our water used to be. And when that did happen, I used to call it HAP, but not hospital-associated pneumonia. I used to call it our harbor-associated pneumonia.
Nice. Definitely a whole bunch of organisms that you have to think about when it's coming from the harbor. So with drowning terminology, there's been a lot of talk recently trying to kind of phase out some older terms like delayed drowning or near drowning. And now really as medical professionals, when we talk about drowning, there's drowning with mortality, so people who drown and die, which is classically what people think about when they talk about drowning. But then there's also drowning with morbidity and then drowning with no morbidity. Many of us have actually drowned because the true definition of drowning is just respiratory impairment from immersion or submersion in a liquid medium. So when you've gone underwater and you've come up, coughing and gasping and such, then you technically have drowned, just with no morbidity or no more mortality. So really important to use that terminology correctly, especially in our medical charts, so we can get the correct information when we're looking at incidents of drowning and patient outcomes and things like that.
Absolutely. What about, you didn't mention wet or dry drowning. Are those still terms that we use too?
Yeah, so those are actually terms that we've phased out as well. The pathophysiology of drowning, it doesn't actually take very much water in somebody's lungs to cause the drowning. And the drowning process is really just a disruption or a hypoxia. So a lot of times what will happen is the person will get laryngospasm, so there won't actually be a lot of water, but the pathophysiology will be the same, just from a small amount of water in the lungs.
And I hear that even for those patients who do experience laryngospasm, as the kind of cerebral hypoxia starts to set in, that spasm kind of eventually in a lot of these patients does break, and they still end up aspirating. So even if you may have an initial laryngospasm, a lot of the pathophysiology, like you mentioned, ends up being the same.
Exactly. So it's not really necessary to differentiate between the two. There was a lot of concerns many years ago with patients having what they were calling delayed drowning, but the WMS has some great guidelines that show if patients are have normal lung sounds, they have normal oxygen saturations, normal respiratory effort after a drowning incident, that sometimes they can actually just be don't even need to be transported to the hospital. I feel like, on the air of caution, anyone who's concerned should definitely come and seek medical care. But there is definitely a subset of these patients that we're able to send home from the emergency department with good exams. And, obviously families need to watch them and take care of them over the next day or so. But if somebody has a good exam after a drowning incident, their prognosis is very, very good.
Yeah, I see you mentioned in particular a study of on-scene decision-making among lifeguards reviewed 1,831 cases of drowned patients with normal clinical examinations, aside from just a mild cough after a drowning event, and found a 0% mortality rate without further intervention. So maybe if they have a little bit of a cough that clears on scene, they don't even need to be transported to the emergency department, like you're saying. If they still have that persistent cough, they should be transported. But then if their examination normalizes and they don't require supplemental oxygen and they have normal pulse oximeters and stuff like that, then you can potentially discharge them. But if they have anything more than that, we need to keep an eye on them, right?
Exactly. Any other respiratory issues or hypoxia, you do need to keep an eye on them because they can have a little bit of a rocky clinical course initially. One thing that people... Sorry. Scratch that. The dogs are very interested in not drowning. So one of the other things that people need to think about is the duration of submersion. If you can get that history from a patient, that is going to be very helpful prognosticating what will happen. If you've had submersion for less than 5 minutes, there's only a 10% chance of death or severe neurologic impairment. So really getting that person's airway out of the water and getting them rescue breaths early is key to improve neurologic function. Interestingly, if you've been submerged for more than 25 minutes, the chance of death or severe neurologic impairment is 99.9%. So these patients aren't going to do very well. Kind of linking back to what we were talking about with hypothermia, though, the tricky thing is you always have to figure out if they're in cold water, did they become hypothermic and then their airway went underwater, or did they drown and now they're cold? So that takes a lot of good history taking.
Yeah, and if there are bystanders on scene, that can be very, very important in trying to establish what went on. Speaking of kind of what went on, prevention seems to really be a good theme among all of these articles that we've discussed so far. I know kind of in the summertime, it's really appealing. You find a few friends, a sailboat, a few beers, go out on the water, have a good time. I hear that might not be such a good idea to combine alcohol and aquatic activities, despite how appealing it may sound. Tell me a little bit about that.
Yeah, on the surface, that sounds like a great weekend. But unfortunately, kind of mixing alcohol and water does not seem to really be a great idea. The other thing that a lot of times people don't do is wear life jackets because they're not cool, or they don't think they need them because they're good at swimming. The problem is if you end up unconscious in the water, it doesn't matter how good you are at swimming, you're not going to be able to help yourself. There was a study done that looked at 1,597 recreational boaters. And found that 85% of the fatalities that happened in the boating-related incidents were in individuals not wearing life jackets. So that's a pretty impressive statistic of the life-saving role that life jackets have. And then about 30 to 70% of people who have drowning in recreational aquatic activities have a detectable blood alcohol level.
Wow, it's time to take social media by storm and make life jackets cool, right?
Yeah, I think we need to make life jackets cool again. Non-alcoholic beer and life jackets. There you go.
That's our work cut out for us for the upcoming summer.
Definitely. I think the other big thing that we probably both see in the emergency department is really stressing and making sure pediatricians stress to parents the importance of water safety for children. Those are like the most heartbreaking cases, is the child that ended up in the pool or in the lake when each parent thought another parent was watching. I've seen some good evidence that when having pool parties and things like that, having one parent of, all the parents that are there be like the lifeguard or the person that is in charge, and they're not talking to other parents, they're not running inside to grab a towel. Their sole job is watching what's going on in the pool. Really important to think about that, making sure people have appropriate fences, have appropriate covers over hot tubs, things like that, just to avoid these opportunities for tragedy.
That's such an excellent point, and like you mentioned, drowning still remains one of the leading causes of death in children, right? It's terrifying, but hopefully with increased public awareness and public campaigns, like we mentioned, hopefully that statistic will change over time.
Definitely, I think just the education, and I think you can't be. Even if your child appears to be a good swimmer, you just can't be comfortable with that being enough. They really need to have an adult eyes on them. And same thing with teenagers, because they tend to, especially male teenagers, tend to have more risk-taking behaviors, and diving injuries are another really tragic things that we see when somebody who is a good swimmer dives into shallow water and then suffers a cervical spine injury and is unable to get out of the water, and that leads to drowning.
Yeah, speaking of cervical spine injuries, when we kind of rescue these patients from the water, does everyone need C-spine precautions, or just those who seem to be at fairly high risk because they did something like dive or they were caught in like a surfing swell?
And that's a really good point that you make. C-spine precautions don't need to be taken for every drowning victim. In fact, just the ones that have a high mechanism of injury or a drowning injury, or a diving injury that was witnessed. If you think about how hard it is to manage an airway when somebody has a C-collar on, if they don't need the C-collar, it's going to be much simpler to manage this kind of terrifying airway with having the neck immobilized.
And your pups feel fairly strongly about that too.
They are really proponents. They both have their own life jackets that they wear at the lake, and they don't consume alcohol either. So we're safe in both of those things. They get life jackets on.
They can be the ones to start our media campaign.
I think they're ready. Woof woof. That's their message to all of their dogs and children.
Well, thanks, Steph, for those excellent points. Any kind of final points on drownings to leave our listeners and readers with?
Pretty well. I mean, prevention is going to be the number one thing for most of these environmental emergencies. And then if prevention, if it happens, airway, and really getting oxygen into that patient, be prepared for a bad airway, and go from there. So hopefully not something that anyone has to deal with on their next shift, but unfortunately I think it is a reality for most of us.
Yeah, and I think to summarize this whole issue, really, and not just these 4 articles, but all 15 articles, which our authors did a tremendous job writing. I think as we move into the era really of climate change, all these extreme weather events are happening with increased frequency, with increased duration, and with increased intensity. So even like North Carolina mountains that didn't expect to be faced with a hurricane this year experienced hurricane and flooding and drowning, and we may be experiencing environmental or weather or wilderness related concerns that we have historically not been seeing in our populations. So really, this is the time to kind of bring environmental medicine really into the spotlight and kind of review these conditions, because like you mentioned, we don't see them necessarily with fair frequency, but when they do occur, they occur with fairly high acuity. And so emergency physicians must be prepared to appropriately treat these patients to prevent some of that high mortality.
Definitely. And I feel like there's little caveats and there's special equipment that can help in the resuscitation of a lot of patients with environmental emergencies. So really important to think about it ahead of time and get your department prepared. Put a quick plug in for the climate change chapter as well, if you're interested in kind of knowing how the world around us changing is really influencing people's health. I would definitely check out that chapter.
And if you're considering of just leaving the Earth altogether and exploring the beyond, we also have a chapter on space flight environment, and the whole issue is just a fascinating read from start to finish. So
it's pretty exciting if you want to, join the space shuttles that are going up, or you're going to start taking care of patients that are doing that. I mean, space travel, I think, is definitely becoming more accessible.
Absolutely. Well, it was actually an absolute pleasure to collaborate with you on this issue, and I'm really excited with what our authors have come up with. So
yes,
I'm excited for all of our readers.
Yes, I want to echo your thanks to all of our authors. They did a phenomenal job in really condensing down these environmental emergencies into very digestible and actionable things for emergency medicine physicians. So thank you very much.
Thank you both for all your hard work guest editing such a great issue and for taking the time to talk about it with me today. Thank you for joining us for this edition of the Emergency Medicine Clinics podcast. For an exclusive discount on the issue we discussed today, focusing on environmental and wilderness medicine, visit us.elsevierhealth.com/expert. Emergency Medicine Clinics is available for individual print subscription with accompanying online access, individual online-only access, as well as on the Elsevier electronic platforms Clinical Key and Science Direct. New subscription and single-issue pricing options are also available on the Clinics app. For more information on the series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on X, formerly Twitter, and subscribe to the Emergency Medicine Clinics podcast on Apple Podcasts and the Google Play Store.